strategies to improve metabolic outcomes for people with diabetes. For that, we have Dr. Assad Akbar over here with us. He's MBBS, King Edward Medical College. He's MRCP Ireland, MRCP UK. He is fellow of American College of Cardiology. He has fellowship in cardiac imaging and in interventional cardiology and structural heart disease from USA. He is member AHA Council, adjunct assistant professor of medicine, New York, USA, and currently he is serving as consultant, interventional and structural heart disease cardiologist, Shifa International Hospital, Islamabad. So let's hear a cardiologist perspective.
Start to my talk then, looking at that particular video. और अभी वो मैं अपने टाइम में से 1 मिनट निकाल लेता हूँ कि वो मैं अजीज़ साहब को भी मिल रहा था, प्रोफेसर अजीज़ुर रहमान को ना, तो somebody who is his class fellow works with me, उनका ऑफिस मेरे साथ ही है शिफा में, डॉक्टर अजीम, और उनसे कोई बात हो रही तो his name came out, तो we figured कि वो उनके क्लास वाले और उनके बड़े अच्छे क्लोज फ्रेंड हैं. तो मैं अजीम साहब को बता रहा था नाश्ते पे ना एक दिन के फाइनल ईयर का जब केई में पेपर था मेडिसिन ए का शायद ना, तो उससे पहले वो टेंशन भी होती है और मेडिसिन का तो पास रेट भी वहाँ 30% है केई में. तो और आप जिस तरह पढ़ भी रहे होते हो और इस तरह ना, तो आपको हर बीमारी अपने अंदर लग रही होती है कि ये भी सिम्टम्स हैं. और तो आई गॉट सो टेंस एट अ पॉइंट के आई थिंक 1 day बिफोर माई मेडिसिन एग्ज़ाम के आई टोल्ड माई फादर के मेरा नहीं ख्याल कि मुझे एग्ज़ाम देने की ज़रूरत है, क्योंकि ये बीमारियों से बचूंगा तो कोई फ़ायदा है ज़िंदगी में आगे चलने का ना. तो और ऑब्वियसली घर की मुर्गी दाल बराबर, ही वो तो मेडिसिन गाय, तो उन्होंने कहा कि मेरी बात पे तो तुम्हें एतबार आना नहीं है, तो यू पिक अप समबडी जो इसके बाद पे तुम्हें एतबार आएगा कि वो उनको मैं तुम्हें दिखवा देता हूँ, तो ताकि तुम मेडिसिन का पेपर दे सको. तो आई टोल्ड हिम कि मुझे ना प्रोफेसर अजीज़ुर रहमान साहब के पास ले जाए कि अगर वो मुझे कहते हैं कि तुम ठीक हो तो फिर मैं एग्ज़ाम दे दूंगा. तो एनीवे वो तो नहीं मैं गया. मैंने कहा कल उन्होंने मेरा एग्ज़ाम लेना, हाउ कैन आई टेल हिम कि भाई सारी बीमारियाँ मुझ में हैं. तो डेफिनेटली समथिंग आई एम इंडेटेड टू प्रोफेसर जावेद साहब हैं, Sajid Vedullah Sahab, and they're all my teachers, and wherever I am, so I'm totally indebted to them. Acha. So thank you to Farmevo for inviting me and the management of PSIM. These are my disclosures. I work as proctor for Boston Scientific and Medtronic. Without using much more of your time, तो diabetes मेरा ख्याल है बहुत कुछ पहले हो गया इसके ऊपर, और दिस इज़ डेटा फ्रॉम 2017 और ये BMJ में पब्लिश है. एंड आई थिंक दिस इज़ प्रॉब्ली जस्ट द टिप ऑफ द आइसबर्ग कि 36 million people in Pakistan currently diabetic. मेरा ख्याल है द नंबर इज़ प्रॉब्ली 3 or 4 times more than that. और what we know is कि cardiovascular disease is probably the leading cause of death in these people. तो what we know, और ये multiple data हैं, and I won't waste your time with it, लेकिन at least जिस इंसान को डायबिटीज़ है और जिस इंसान को cardiovascular disease, the risk of them dying from it is at least double that of a normal person. What we know again कि अगर एक बंदा इसको डायबिटीज़ है तो, and if they are supposed to live past 70, and if they have diabetes and cardiovascular disease, they are unlikely to cross 60, which is extremely remarkable when you think of it in the grand scheme of things के पाकिस्तान में एक एवरेज एज इज़ अराउंड mid-60s, जबकि यूरोप में 80s में है, अमेरिका में थोड़ी सी कम है. तो हम पहले ही एवरेज एज इज़ 60s. तो अगर डायबिटीज़ भी और कार्डियोवास्कुलर डिजीज़ है तो आपकी एवरेज एज अगर 12 साल कम हो जाती है तो यू आर टॉकिंग अबाउट डाइंग इन 50s, जो कि बड़ी राइप एज है, जिसमें बाकी दुनिया में तो सोच भी नहीं सकते कि इस उम्र का कोई पेशेंट आएगा. तो हाउ वी क्लासीफाई देम, डायबिटिक पेशेंट को हम बेस लाइन पे ही लो रिस्क से ऊपर रखते हैं. जो सबसे लोएस्ट कैटेगरी है इन टर्म्स ऑफ रिस्क, वो हमारी मॉडरेट रिस्क है कि ये वो बंदा है जिसको अभी 10 साल से भी कम हुए हैं डायबिटीज़ डायग्नोज हुए, एज भी कम है, कोई और कॉम्प्लिकेशन भी नहीं है. फॉर अस ही इज़ ऑलरेडी स्टार्टिंग ऑफ विद अ हैंडीकैप. और फिर अगर 10 ईयर से ज़्यादा है तो दे आर हाई रिस्क, एंड देन इफ इट्स मोर देन दैट तो इट्स वेरी हाई रिस्क. So again, some more data, 1/3 of people with diabetes will have coronary artery disease, and 9 out of 10 people will have some degree of atherosclerotic disease in their lifetime. अच्छा, अब जो कोमॉर्बिड्स हैं, जिस तरह पहले ये बात हो रही है कि डायबिटीज़ डजंट कम अलोन, और वो अभी they were mentioning course and stuff which is amazing because पाकिस्तान में इतनी awareness नहीं है कि डायबिटीज़ सिर्फ अकेली नहीं आती है. 1/3 of these patients come with high blood pressure, इनके अंदर स्टैटिन का भी मसला है, इनकी प्लेटलेट्स भी स्टिकी हैं, जिसमें प्रोफेसर जावेद अकरम वाज जस्ट सेइंग. तो इट्स अ मल्टी ऑर्गन सिस्टम इशू और इट्स अ सिस्टेमिक इशू. तो ये सिर्फ एक चीज़ नहीं है. एंड प्रॉब्ली द कॉमनेस्ट कोमॉर्बिडिटी विद देम इज़ हाइपरटेंशन. अभी हमने पहले देखा है कि जिस बंदे को डायबिटीज़ है वो उसकी पहली लाइफ एक्सपेक्टेंसी नॉर्मल बंदे से कम हो गई है, जो मर्जी भी आप कर लें. और अगर हाइपरटेंशन भी आ गई है तो ऑलमोस्ट ये रिस्क और डबल हो जाता है. तो एंड ऑलमोस्ट 1/3 ऑफ देम हैव हाई ब्लड प्रेशर. और मेरे ख्याल में पाकिस्तान में तो प्रॉब्ली 5% भी डायग्नोज नहीं है, क्योंकि अवेयरनेस नहीं है. तो ये जो सब इश्यूज हैं कि डायबिटीज़ कम्स विद हाई स्टिकी प्लेटलेट्स, हाई ब्लड प्रेशर, कोलेस्ट्रॉल, obesity, all of these lead to obviously mortality in one way or the other. और जो commonest चीज़ें हैं जिनकी वजह से mortality आती है, जो at least final outcomes हैं, वो heart failure है, MIs है. If you just combine these two, so that is around 35%. CKD on its own is 35%. जो हमारे पाकिस्तान में इतना मरीज़ है डायलिसिस पे गया हुआ, तो I was reading up on it कि commonest cause is renal stones and followed closely by diabetes. So diabetes again is a major player in not just cardiovascular outcomes but renal outcomes as well. Because I was going to present in front of my teachers, so I thought कि मैं अपने ख्यालात का इजहार नहीं करूँगा, तो I'll just show you what the guidelines say. So these guidelines came out just in August 23. So just quickly, जो class 1A हैं recommendations in terms of the new recommendations as compared to what we were फॉलोइंग फ्रॉम 2019 कि एक पेशेंट है जिसका अगर टाइप 2 डायबिटीज़ है तो क्विकली आपने रिस्क को कैलकुलेट करना है, जिस तरह जावेद साहब पहले बोल रहे थे. एंड देन प्रोफेसर इमरान साहब जस्ट मेंशन के ओबेसिटी, फिजिकल एक्सरसाइज इज़ क्रिटिकल. और जो नई गाइडलाइंस हैं जो जस्ट केम आउट अ मंथ अगो, दे रिकमेंडेड एज टाइप एज क्लास 1A रिकमेंडेशन. ओके, सो and then in terms of reducing their atherosclerotic risk, so what we know is, and up till in 2019 when these gliflozins came and all of these newer generation drugs like SGLT2s and GLP-1s, we were only using them in patients who had definitely diagnosed heart failure, whether it was reduced, preserved only came recently, but reduced ejection fraction wise we were using these drugs pretty commonly from 2020 onwards. So what we know now, based on all the data that we have, is that even if these patients do not have any established heart failure, you can still start them, because they're not just improving their risk of not developing heart failure, but also decrease their risk of developing cardiovascular disease. Again, in terms of the new recommendations, what they have said is class 1A indication, if they have developed heart failure with reduced ejection fraction and they have type 2 diabetes, if you start them on any of the gliflozins like SGLT2, either of them, they reduce the risk of heart failure, hospitalization and cardiovascular death. Or and we have Professor Shehbaz Saab in the audience as well, and we have been on these multiple forums trying to promote this culture of preventing heart failure admissions. And what we know from all our cardiology outcomes, and Bilal Mahyuddin Saab knows as well, once these patients with reduced ejection fraction, they get admitted to the hospital with their first episode of heart failure decompensation, their life expectancy goes down steeply and they never come back to their baseline, no matter what medicine you start at that point. So our purpose with these patients, once we know they have diabetes, is to prevent their first admission. In terms of the other recommendations, again, we saw that 35%, every 1 in 3 patients with diabetes is going to develop some degree of chronic kidney disease. SGLT2 inhibitors are recommended as a class 1A indication to be started even there as well. In terms of what's different, and as we were talking about it earlier, GLP-1s are definitely there, but if patients with a high risk of target organ damage are there, and diabetes are there, and they don't have any evidence at the time that you are looking at them, still you start them on SGLT2 inhibitors, you are going to prevent multiple morbidity outcomes. And this is what they have come up with as one of their final slides, that you need to prioritize. And so the 2019 guidelines came out with a nice table where it showed that if somebody is diagnosed as diabetes at the time of their coronary event, and they are not on metformin, then you don't start them on metformin as their primary drug of choice. You start them on either SGLT2s or gliptins, and if they are already on a metformin tablet, then you can add it an SGLT2 inhibitor to it. But as compared to general population, and I know there are people who are way more expert in managing diabetes than I am, where we start metformin as the first therapy. For somebody with cardiovascular disease, you can easily start them on an SGLT2 inhibitor as their first line therapy rather than waiting for them to be diagnosed with diabetes. Now, the other thing which is more critical in these guidelines is that you don't, we knew it, but now it's part of the guidelines that you don't worry about their HbA1c. Even if they are not diabetic, you can start them on an SGLT2 inhibitor if they have cardiovascular disease and they have presented to you with an MI with reduced ejection fraction. All just to prevent this, these are their final statements where what they've, and I think these three are probably encompassing the entire discussion that we have had so far. Anybody with diabetes, risk factors, no diagnosed atherosclerotic disease yet, you start them on SGLT2. With diabetes, reduced ejection fraction, you start them on SGLT2, all class 1 indication. With diabetes, preserved ejection fraction, you still start them on SGLT2. All of these are class 1A guidelines. This is just a table to say diabetes and cardiovascular disease, even if they don't have heart failure or established cardiovascular disease, you can start them on it. Multiple mechanisms, how it acts, so we won't waste time on it. Just, I was talking to my fellows a couple of days ago and we were talking about gliflozins, and I asked them if they know, we always read about SGLT2 inhibitors, if they ever thought where the SGLT1 inhibitors are. So only 1% knew that they existed in the gut, and only 10% of them are responsible for reabsorption of sodium and glucose from the proximal tubule. But once somebody started on these SGLT2 inhibitors, these SGLT1 inhibitors get overexpressed, and they start absorbing about 40% of the sodium and glucose. So that sort of takes away a bit of the edge of these SGLT2 inhibitor action. The other thing which is really important for me, and I tell my fellows as well, that the commonest thing that somebody comes in with heart failure gets is Lasix, or no matter what stage of medical journey the physician is at, they know that somebody who's in florid heart failure, they can give Lasix without thinking about much else. And one of the things that people need to know when they're giving Lasix is if somebody is cachectic, has low albumin, Lasix is not going to work because it's a prodrug. It only works in combination with albumin. So somebody who has heart failure, you think they need decongestion, you are giving them Lasix. Even there, if you start dapagliflozin, even though you might not think that it might get absorbed from the gut, at least as long as it increases the albumin levels, it will increase the efficiency of IV Lasix that you're giving. So that's something to consider once you're treating these difficult to treat patients. In terms of outcomes, we'll quickly go through them. All of you probably know it. EMPEREDGE is an outcome trial, randomized, almost 90 patients had to meet an endpoint for them to stop the trial. They enrolled about 4,500 patients, and what they found was 35% reduction in the risk of hospitalization or heart failure. And why was this the primary outcome? Because we know for a fact, as soon as these patients get admitted, they are on their journey to dying from heart failure. 1/3 of the patients with even NYHA class 1 and 2 will die within 3 to 5 years. And if you are talking about NYHA class 3 and 4, 3 and 4 are the ones which you see in the hospital. 50% might not be there in 5 years. So this course is way more aggressive than a lot of cancers that we know of, but we don't consider it that serious when we're treating these guys. So this is just to say that they did a subgroup analysis, and what they found was that concomitant therapy did not make a difference to the impact of empagliflozin. In terms of their outcome trials for heart failure, for reduced ejection fraction, what they found was that it reduced cardiovascular death due to heart failure by about 25%. And obviously, that sort of is a translation of reducing their heart failure hospitalization. We always treat heart failure hospitalization or angina or unstable non-ACS symptoms as morbidity, but when you're talking about heart failure, morbidity of which this particular morbidity essentially means you're increasing their mortality in the short to medium term even. People with preserved ejection fraction and using empagliflozin, what we know is this is a field, this is an area of cardiology where we haven't been really successful. We have some data from the RAILS trial that aldactone might help with preserved ejection fraction, but if you look at the numbers, like it's a very small group of patients, and it came out positive because the entire cohort was very tiny, and obviously it's a subgroup analysis, it wasn't meant for them. And this is probably one of the few drugs other than RNE maybe, which has improved outcomes in patients with preserved ejection fraction as well. Again, multiple mechanisms, and we saw with diabetes and all the way diabetes increases mortality, and one of them is that almost 1/3 of them will develop CKD at some point. So again, it doesn't just help our heart, but it also is helping our renal outcomes as well. What are the recommendations of diabetes and chronic kidney disease? Obviously, they have to be treated with LDL-C lowering. Previously, we only gave them moderate intensity statins, but now you can, with atorvastatin and probably pitavastatin, probably you can use a slightly higher dose of it because they don't really get excreted via kidneys, whereas 10% of rosuvastatin does. So maybe if you're using atorva or pitalo, you might be able to use a bit higher dose of it, and then you can always add ezetimibe to it. HbA1c targets should be strict. Professor Javed Saab was mentioning it, Professor Imran Saab was mentioning it. Even here, as long as their EGFR is better than 20, you can use an SGLT2 inhibitor, and that's a class 1A indication. For statin therapy with diabetes, the newish guidelines would recommend that you bring them down much more aggressively than we used to previously. Diabetes, we have already mentioned it. You have to sort of cover all these aspects rather than just reducing their HbA1c. And SGLT2 inhibitor probably covers most of these aspects. So ESC 23 guideline, they recommend SGLT2 in patients with atherosclerotic disease, without diabetes, with heart failure, without diabetes, with heart failure, with preserved ejection fraction, with diabetes, and then patients with chronic kidney disease who do not have heart failure, but with diabetes, they will improve their outcome. Although these are deduced based on these studies which did not improve hardcore outcomes. The data that we have from EMPEROR Reduce and EMPEROR Preserve does not show any significant or definite reduction in patients ending up on dialysis, but what we have seen is slight improvement in their EGFR, or at least conservation of it. So they are doing these EMPEROR CKD trials and stuff to prove it, but right now at least we know that this does not worsen your EGFR. So ESC is now calling it the statin of the 21st century, and I think if you look at the data that is out there already and probably what's coming up, it's probably not that wrong to call it one. Perfect. Thank you.